Welcome to IM Updates. This is Yen. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from July 10th to July 17th. Here's the overview. On July 12th, the British Society of Gastroenterology published 2026 guideline on the diagnosis and management of adult celiac disease. The most transformative change is the conditional recommendation for no biopsy diagnostic pathway, allowing symptomatic secondary care patients with IgA-TTG titers equals or more than 10 times the upper limit of normal to be diagnosed without endoscopy. Biopsy protocols have been enhanced to require at least 4 samples from the second duodenum and 2 from the bulb, placed in separate pots with a single bite technique now recommended to improve histological quality. The guideline formally defines and provides management pathways for potential celiac disease, seronegative celiac disease, and the newly diagnosed entity of ultra-short celiac disease. Gluten-free oats are now conditionally encouraged for most patients, with clinical monitoring for the minority who may react. Follow-up has shifted toward patient-initiated care for well-adjusted individuals, reserving structured surveillance for those with poor adherence, persistent symptoms, or complications. Universal dual-energy X-ray absorptiometry scanning 1 year post-diagnosis and pneumococcal vaccination for all newly diagnosed patients, representing major additions. While refractory celiac disease diagnosis now mandates flow cytometry as the reference standard. On July 13th, the ASCO published 2026 Living Guideline on Systemic Treatment of Ovarian Cancer Recurrence. It introduces several paradigm-shifting updates from prior static guidelines. Most notably, the role of PARP inhibitors has been significantly restricted. They are no longer recommended for treatment of recurrent disease and are limited to maintenance only in highly selected BRCA-mutated patients. The guideline also introduces new evidence-based options, including a strong recommendation for mirvetuximab soravtansine in folate receptor alpha high platinum-resistant disease based on the MIRASOL trial, and a conditional recommendation for relacorilant plus nab-paclitaxel from the ROSELLA trial. Conversely, trabectedin added to pegylated liposomal doxorubicin is now strongly discouraged due to lack of efficacy and increased toxicity. Surgical recommendations have been more cautious, with insufficient evidence to routinely recommend secondary cytoreduction or HIPEC, emphasizing careful patient selection for complete gross resection. July 14, the WHO issued its first recommendation on the use of doxycycline post-exposure prophylaxis, commonly referred as doxy-PEP, for the prevention of bacterial sexually transmitted infections among men who have sex with men and transgender women. Based on high to moderate certainty evidence from 3 randomized controlled trials, a single 200 mg dose taken within 72 hours of condomless sex reduces syphilis and chlamydia by approximately 80 to 85%, gonorrhea by about 48%, and any bacterial STI by 73%, with no difference in serious adverse events compared with no prophylaxis. However, given legitimate concerns about antimicrobial resistance, particularly in Neisseria gonorrhea, the guideline strongly encourages context-appropriate antimicrobial resistance monitoring alongside implementation. On July 16th, the European Reference Network on Genetic Tumor Risk Syndromes published Cancer Surveillance Guideline for individuals with repeating hematoma tumor syndrome. Compared with the 2020 guideline, key updates include breast cancer surveillance recommendations are now aligned with BRCA 1, BRCA 2 protocols, including annual MRI starting at age 25 with mammography every 1 to 2 years from age 40. Thyroid surveillance continues to be recommended from ages 10 to 18, but follow-up intervals may now be extended to 2 to 3 years if 2 initial ultrasound examinations show no suspicious findings. Endometrial cancer surveillance remains an option starting at age 35 to 40 years with annual transvaginal ultrasound, though evidence for survival benefit is lacking and endometrial biopsy is considered option. The most notable change is for renal cancer, where routine regular surveillance has been de-escalated to a single baseline imaging exam at 35 to 40 years, with no further routine follow-up if results are normal. Colorectal cancer surveillance continues to begin with a baseline colonoscopy at 35 to 40 years, with subsequent intervals risk adapted based on polyp burden. For melanoma, the guideline now recommends a baseline skin examination at age 30 by an expert, followed by surveillance only as dictated by individual risk factors, rather than routine ongoing screening for all. On July 16, ASCO published guideline update on breast cancer follow-up and surveillance after primary treatment. Key recommendations include: first, intensity-based post-treatment surveillance of 3 risk groups. Low-intensity group is defined by DCIS stage 1 hormone receptor positive or TNBC or HER2 positive, equals or more than 5 years from diagnosis. Follow-up with annual clinical visit by survivorship clinics, advanced practice providers, or primary care. Mammography needs to be done every 1 to 2 years for patients equals or more than 50 with low-risk features like T1, low-grade, node-negative, ER-positive, breast-conserving surgery, or recurrence-free at 3 years. Annual for less than 50 or TNBC or HER2 positive. Intermediate intensity group is defined by patients on endocrine therapy alone or other low-risk systemic therapies. Clinical follow-up every 6 to 12 months for 5 to 10 years with oncology team or survivorship clinic, and annual mammography for breast-conserving surgery. Annual contralateral for unilateral mastectomy. High-intensity group is defined by TNBC with residual disease after neoadjuvant chemotherapy, HER2-positive residual disease, germline mutations, inflammatory breast cancer, or on CDK4/6 inhibitors. Follow-up every 3 to 6 months for up to 10 years after active treatment, and annual mammography for BCS. Annual contralateral for unilateral mastectomy. Second Memo 50 trial was an RCT of 5,235 women, equals or more than 50, recurrence-free at 3 years. It showed that less frequent mammography, biannual or triennial, was non-inferior to annual mammography for recurrence-free interval, overall survival, or breast cancer-specific survival, and no differences in quality of life, distress, worry, or fear of recurrence. July 17th, European Association of Urology updated guidelines on urological infections. Key classification changes include elimination of uncomplicated and complicated UTI terminology and replaced with new classification distinguishes between localized UTIs, for example cystitis, which typically treatable on an outpatient basis, and systemic UTIs, like pyelonephritis or prostatitis, which may require blood sampling, imaging, IV antimicrobials, and hospitalization. New chapter on diagnosis and management of HSV infection includes genital ulcers, diagnosis via PCR or culture, and treatment with acyclovir or valciclovir 5 to 10 days for first episode and 2 to 5 days for recurrence. New chapter on diagnosis and treatment for fungal UTIs. Candida albicans is predominant with 50 to 70%. Asymptomatic funguria generally requires no treatment. Treatment considered in neutropenic patients, low birth weight infants, or before mucosal breaching procedures. And species-specific susceptibility testing is recommended. Move on to FDA approvals. On July the 14th, the FDA approved gedatolisib. The brand name is Revtorpic, in combination with fulvestrant with or without palbociclib for adults with hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer without a PIK3CA mutation detected following progression on or after treatment with at least one line of endocrine therapy in a metastatic setting. Efficacy outcomes are as follows. The prescribing information includes warnings and precautions for stomatitis, dermatologic adverse reactions, hyperglycemia, and embryo fetotoxicity. On July 16th, the FDA had approved Lymphedra or enlicitide as a treatment to be used with diet and exercise to reduce LDL-C in adults with high cholesterol or who have an inherited type of high cholesterol called heterozygous familial hypercholesterolemia or HeFH. The efficacy and safety of Lymphedra were demonstrated in 2 randomized double-blind placebo-controlled trials in a total of 3,207 adults with severe hypercholesterolemia, including those with and without HeFH, who were already taking maximally tolerated statin therapy. The primary endpoint for both trials was the percentage change from baseline to week 24 in LDL-C compared to placebo. In the first trial, the average percentage change in LDL-C from baseline to week 24 in the Lymphedra group was minus 56% compared to the placebo group. In the second trial, the average percentage change in LDL-C from baseline to week 24 in the Lymphedra group was minus 59% compared to the placebo group. The frequency of adverse reactions was similar between those treated with Lymphedra and those receiving placebo. That's all for today's episode. Thanks for watching. See you on next one.